Go ahead. You can start.
Right. Okay. Good afternoon, everybody. Welcome to our webinar this afternoon, our panel discussion this afternoon, the title of which is Shaping an Equitable Post-COVID World, the Role of Global South Think Tanks. So we have many think tanks represented here, but the purpose of our discussion is to throw our minds at this conundrum about vaccine equity in different parts of the world and to make sure that everybody is as safe as is possible. I'm Kwame Owino from the Institute of Economic Affairs, and I welcome you to this panel discussion hosted under in partnership with Southern Voice and as part of the third Southern Voice Research Conference. So as you can tell from the program, we have a title of the discussion, which is basically to explore the preparation for the next pandemic and fostering vaccine equity. I'm Kwame Owino, and I'm session moderator for today. We have 4 panelists, and before I introduce the panelists, I'd like to ask our colleagues at Southern Voice to play, as part of the preface, a 1-minute video to establish the foundation for the discussion after this. So can we have the video played, please?
A race that could make history. As rich countries hurry to protect their own people from COVID-19, the developing world must try to keep up. Britain's normally a favourite, not this time, with just 5% of its population vaccinated. On 9%, South Africa's looking to break monopolies held by the big pharmaceutical companies, so countries like Bangladesh can produce vaccines for themselves. Over 100 governments support the call to lift vaccine patents, but not Germany, putting profit before lives. And no way, says Great Britain, holding millions of doses more than it needs. The United States says it's in favour, but hey, leadership's about action, right? Just ask Uganda, with less than 1% of its people vaccinated. You've got to say, folks, no chance at all. The wealthy countries surging ahead. And it's this agony for the developing world out of this race. They just can't compete. We all want to see an end to the pandemic. Until every country is vaccinated, the only winner is the virus.
All right, thank you. So, I mean, the enduring message from that short clip is that until every person in every country is vaccinated, the only winner is the virus. And that places us in the position to start our discussion today. So one of the things we are asking ourselves is, how is the distribution, or what accounts for the different rates at which vaccinations have gone globally? And our discussion will try to answer questions about, it is very, very clear that some inequity exists, what are its causes, and to explore what the solutions are. And ladies and gentlemen, we'll try and conclude with some call to action, asking different responsibility bearers to do certain things, or as think tanks to help them to reach certain conclusions towards ensuring vaccine equity. Because it is clear, as it says again, unless everybody is vaccinated, the only winner is the virus. And I don't think that there's anyone who wants the virus to win. So to start our conversation today, we'll be answering a couple of questions. And about those questions, I'll start with our panelists. We have 4 panelists, and allow each of them to introduce themselves in turn. But basically what we'd like to ask ourselves, each of the panelists, is what's the state of vaccination in the country and in the region in which you come from? And to start with that, I'll start with Carlos. Carlos, please tell us what's the state of vaccination in Colombia, where you were, and then tell us what some of the drivers and what you think is, what does that say about vaccine equity generally? So you have 2 minutes. I'll try to go by all the panelists first, so you can introduce yourself and your institutional affiliation, and then go ahead to answer the question.
Sure, Kwame.
Thank you.
Sure, Kwame. Thank you very much for the invitation. So let me go very fast. I'm leading a think tank based in Colombia, focused on future and innovation in healthcare. And of course, COVID and vaccination has been one of the core think issues in for our team. So the state of vaccination. I'm going to talk a little bit about Latin America because I guess I'm the only from Latin America. So it's a very different scenario. We have countries like Chile with at least one vaccine, 86% of population, and full vaccination for 80% of people. And let's say the average of Latin America is around 50% of vaccination. My country is 60% of vaccine, at least one dose, and close to 50 for the full scheme. And countries like Nicaragua are far away, like 20% for the first dose and 10% for the full scheme. So very different scenario in Latin America. But it was also a very different scenario as related to COVID affectation. Let's say that measure related to deaths relative to population. So what we have seen is that countries most affected in epidemiological terms are countries like Brazil, Argentina, and less affected countries are those like Nicaragua, Haiti, and Venezuela. This would represent some sub-register of deaths in those countries. But definitely countries, the pattern of the behavior of the virus in the region is different. It's completely different. So it's very important in our region to start asking the question: what should be the goal if we are thinking about equitable?
Okay, thanks a lot. I'll go next to Fenny. Fenny is from Ghana. Please introduce yourself and let us know what's the state of play in Ghana regarding vaccination rates, and at the same time, the mortality and morbidity rates coming from COVID-19 infections.
Thank you, everyone, and good afternoon. It's 12 o'clock here in Ghana. My name is Fenny. I am a senior research fellow at the University of Ghana. I'm also a health economist. Briefly, I'd like to give an overview of where we are when it comes to COVID situation in Ghana. We recorded about 130,000 COVID confirmed cases, 98% of which of this number have recovered. And we have lost 1,203 people. And even though this number may be relatively smaller than what we've seen in other countries, these are close friends, breadwinners, and colleagues that have contributed a lot to this economy. And it's really sad to see how these numbers have risen over the past 6 to 7 months. Again, we know that there's complete underfunding of our public health systems. This has gone on for quite some time, and COVID has worsened the situation as we see it. Fortunately for us, Ghana was one of the first countries in Africa to have received vaccines through the COVAX facility way back in February. Since then, we've had a number of batches of different types of vaccines coming in. We've had Johnson & Johnson, AstraZeneca, we've had Moderna, we've had Pfizer, we've had Sputnik. And this shows you the level of inequities that we have experienced as a country. We've had delays in vaccines reaching us, and we have relied on both bilateral and multilateral agencies to be able to get the vaccines that we need for our people. So far, we have had about 7 million vaccines from these different range of sources that I've listed out. And we've had governments like the UK, United States through the COVAX facility, the German government, Iceland, Denmark, Norway, Germany, giving us vaccines so that we can vaccinate people in Ghana. So that should show you how difficult it has been for us to get vaccines in country for the many people who we need to vaccinate. And one of the things I need to point out was we had intended as a country to be able to vaccinate at least 20 million people by September this year. Unfortunately, those who are fully vaccinated account for just 4% of that number. We do continually vaccinate people, but we have so far distributed about 3 million doses of the vaccine. But those who have had their 2 shots, for example, are way less than that number. So we continue to see these inequities playing out in Ghana as well. And this is the story for many, many countries in Africa. I'm sure Dr. Owino can tell us more about it. Thank you.
Thanks a lot, Amma. Thank you very much. Now we'll go to Neelesh. I mean, Neelesh comes from India. I think a very large country. Most of the countries represented in our panel tend to be small or medium-sized countries. So let's hear what the challenge is. I mean, it's a huge challenge as well, but let's hear what the response has been. So Neelesh, please tell us about what's the state of play in India and what are some of the drivers of these successes and challenges that have been experienced.
Thanks, Kwame. And India definitely is a very big country with over 1.3 billion population. And in fact, the second wave with the Delta strain coming through, and we had a very, very massive second wave. And till date, India has reported in excess of 30 million cases and 0.4 million deaths. So it was a great challenge, especially when the second wave came. India was not that prepared. And initially, when we started off the vaccination, despite being a very, very big pharmaceutical base available in the country, we had prioritized our high-risk population, which was medical and healthcare workers and your senior citizens above the age of 60 years, and those with comorbidities, especially the cardiac and others. So we started off with that, and by the time the second wave hit us, we were sort of not able to respond to that challenge with the kind of ferocity or the kind of force which we would have liked. But that was a huge wave, and a lot of cases were happening. And currently, the situation is a lot more under control, with more than 1 billion cumulative doses have been given, at least. And if you look at the total 2-dose full vaccinated individuals, we have crossed 30% of the population, and at least with a single dose, we are close to 70%. So India has made impressive gains despite having a large population base. But despite that, we have pockets of vaccine inequities, especially the northeast part of the country has access issues. And there are pockets of districts where immunization rates are as low as 6 and 7%. And even within the gender groups, the female gender is lagging behind the male gender. And there are obvious reasons to that, where the whole society has been patriarchal for ages. And somehow we have sort of missed that part where we needed more sort of female-centric or women-centric services. And still there are pockets, even in the sort of national capital territory, where for every 100 males, only 60 females have been vaccinated. So there are obvious gender gaps. There are geographical pockets where access issues are there. And although India was fortunate that we had our own pharmaceutical industry and we were able to get those supplies, but the distribution challenges, the wastage which happened in the initial days, so all these things were there, and we are trying to sort of work around those issues. Thank you.
Thanks a lot. I mean, so we have seen so far that, well, while most of the framing of this debate has been a north-south or rich country, poor country argument, for the purposes of access, it's looking as if it's a little bit more than that, because there are domestic sector dynamics and there are also international global dynamics as well. So I'd invite next Jacky Kagume from the Institute of Economic Affairs. Go ahead, Jacky.
All right. Good afternoon, everyone. My name is Jacqueline Kagume, and I work at the IEA Kenya. I'm a program officer, and I'm glad to be part of this discussion. So in terms of brief status update on the Kenyan context, the background is that Kenya gets its numbers. The Ministry of Health in Kenya prepares and highlights numbers daily, on a daily. So the most, as of Monday, the 8th of November, the total number of COVID-19 vaccines that had been received in the country was about 8.9 million. And the first dose, just in terms of another brief history, the first dose of vaccinations was with the AstraZeneca vaccine, and this began on the 5th of March of this year, 2021. Then looking at now the actual vaccination numbers, so as of Monday, which is the 8th, we had 5,691,000 persons who've been vaccinated, and of this, we have around 3.8 million who've been partially vaccinated, or those who've received only their first vaccine. And then we had another about 1.8 million who've received both vaccinations, or those who are termed as fully vaccinated. And in terms of percentages, that's less than 4% of our total population. So Kenya has put in place plans to try and vaccinate at least 26 million of the adult Kenyans. That's by the end of June of next year. But the targets for this year that we have are, the country intends to vaccinate at least 10 million. So if you put that comparatively, based on what we have so far. So we've vaccinated around 5.6 million so far, but our target for the end of the year is about 10 million. So we seem to be a bit off the mark, because we've barely done half of what we intended to have done, and we can see that we are almost coming to the end of the year. So that's the first basic one. Then in terms of the cumulative, the testing, one of the things here that we've seen was that the level or the rate of testing has been very low. So far, since the outbreak of the virus or the disease, up until now, we've only had about 2.7 cumulative tests. And then out of this, the total number of cases that have been confirmed are about 253,000. Then out of this, we have the recoveries being around 247,000, and the total number of fatalities that we've had are just about 5,000. So that's broadly the status update of the COVID numbers, where we are at, and we'll provide more details in subsequent questions. Thank you.
All right. So I think we've seen so far. Let me just alert our viewers. I've been unfair to the audience that you can send your questions through the chat box, and of course I'll feed them into to each of the panelists in turn. And at the same time, for those who would like to tweet, please use the hashtag Southern Perspectives as you ask any questions, because we'll be monitoring that as well and try to get them to be answered. But we're going to the second part of the question, which is basically asking about what was, there were market pressures. And I think Neelesh has alluded to this, the fact that India, one of the largest vaccine producers globally, faced the Delta variant that came in February or March this year and halted the distribution of vaccines, because of course the country decided, for very sound reasons, to actually feed or to provide access internally, leading us to the question about how the government respond to existing market pressures, because besides just the question of vaccine production, there are also market pressures that actually did occur. So I'll start with my colleague at the Institute of Economic Affairs, Leo Kemboi, to tell us how government of Kenya responded or tried to respond to existing market pressures and disruptions that affected domestic access to, and obviously, access to vaccines, since Kenya does not produce vaccines for itself. Leo.
Yeah, so the government of Kenya has targeted to vaccinate almost 27 million Kenyans. When the issue of access became more prominent, because the first point of reliance was the COVAX facility, but as soon as India had the more serious Delta variant, the exports from COVAX became low. So part of what government of Kenya did was to acquire the facility from World Bank $130 million to try and get the Johnson & Johnson vaccines. That is still part of the pipeline, and the vaccines were supposed to come in 1 million every month from August, but because of the queue issues, that one has not been able to come through. Secondly, the government of Kenya, through the bilateral means, also tried to source through what they call the friendly nations that already had stocked up vaccines. This includes the US. That's why Kenya was able to get a variety of Moderna, Pfizer, and other countries in Europe who have been able to do that mass vaccination. The market pressure, the biggest market issue is that what as economists and policy scholars, and generally the people who follow this serious issue of vaccination, is that there was an inadequate response. Because what most people felt is that even if government of Kenya was to buy vaccines at the premium market rate, which is almost $30–40, it would cost an equivalent of not less than $900 million, which is Kenya shillings 90 billion. So part of it was that reluctance in the first place, but generally to be able to put money on the table and be able to get ahead into the queue. I can say this because comparatively in the region, there are countries in the EAC like Burundi, which have faced consistent problems, epidemics and the rest of the things and civil strifes. And those ones are countries that should have gone to COVAX. So this is just to explain the context. So that was the response to the market problem that government of Kenya provided. Thank you.
All right, thanks a lot. So, I mean, as we go forward with the discussion, I haven't seen questions yet, but we are seeing that in addition to the fact that there were shocks in the health shock itself, there were other market shocks that came about from the fact that, look, if India is a dependable vaccine provider globally, and then it has a domestic problem, then obviously the political pressure becomes immediate for corporations or even for the government to insist on self-provision. And that in itself generated some questions, which we students of economics, students of economics might call some kind of market failure. I'd like to come to Fenny to tell us how, because you identified the differences, apart from the global access problems, inequity, you identified inequity at national levels, in terms of access to women and a few other vulnerable groups, and perhaps incomes, and it is possible as well that vaccination in Africa, some of the analysis says that it's most intense in the capitals and in urban areas. So how did the government of Ghana respond to those market pressures, but also to domestic pressures related to who has access based on where they are, or who has access based on their gender or ability to access public services generally? Fenny?
Yeah, so thank you very much for this. And it's quite an eye-opener to realize that we are not the only ones who went through a lot of these market pressures when it came to a very critical point in time to get vaccines. And one of the things I need to highlight is that we did have the voices of the people, especially when it came to how much we would spend on vaccines and how much we would agree for the kind of prices that were being quoted on the market for vaccines, when we knew that we could get them at relatively lower prices that other countries were getting them. So this pushback from the voices of the people and CSOs and other voices that came through shows you how the different groups of people can put pressure on governments to align to what the right prices should be when it comes to vaccines. And one of the things I need to also point out is that yes, we're going for loans to buy vaccines, but it's making us fall into higher debts. Already we have very high debts, and then we are going for loans from the World Bank for vaccines. And this is a very critical point in our time when, yes, we want to see health expenditures go up, but how are we going to domestically gather our resources so that we don't fall on loans time and time again and worsen the situations that we already have? So one of the things that the Ghanaian government did was to look at some of the fiscal measures that we can use within our own context so that we do not have to go back and borrow as we've always done. So there was, one of the things was to levy. So there was a tax levy so that we could get some money into the health sector. So, I mean, of course, this will have a pushback from everyone. Nobody wants to pay taxes, but really we needed to be able to do something. So yes, there was some revision of our tax laws so that we could get some of these taxes raised and get some money into the health sector. So this has been done. We have seen a very notable increase in our GDP per capita when it comes to health spending, which is a good thing because we had, for several years, made a demand that we still need to spend more money on taxes. And then the government has also used digital technology, for example, to improve access to remote areas. We do have Zipline supplying vaccines to remote areas using the drone technology. We've been able to supply about 800 districts in very remote places using this new digital method. So access is much better. We've also seen problems when it comes to COVID. Really, it's the informal sector that suffers. We have about 70% of our businesses within the informal sector. The government has also made provision to take care of small and micro businesses, medium, scale businesses, to help them be able to face the difficulties of the past 1.5 years. So yes, the government is doing its bit, but again, my problem is we should not end up in further debts because we are going to borrow to pay for vaccines and pay for other things within our health sector. Thanks, over.
Okay, thanks, Fenny. So what we're seeing here is a claim that, look, vaccination is a good that is required. I think governments take responsibility for it. But there are also domestic pressures related to the size of the economy, the fiscal space that the government has, leading us to ask who should pay for vaccination. I'd like to come to you, Carlos Felipe. Tell us who paid for the vaccination that has taken place in Colombia and in the region that you come from. But more importantly, what do you think are the ways to ensure that it happens faster? Because it suggests, at least the African example seems to suggest that there's a resource problem on one side, and then the second part is basically global access, so that even if you had the money was available, I think there are bottlenecks in the provision, global provision of vaccines that would have to be dealt with at the same time. So please.
Okay, so let me start by let's say trying to reframe the issue. I think that all this discussion regarding vaccine equity has emerged by the statements of the World Health Organization saying, well, we have a target and every country should have at least 10% of X% of the population. I don't remember the set, but they set a global target of vaccination for every country for the same time. I think that's a terrible misunderstanding, because that is not the epidemiological pattern of the of COVID. Yeah. COVID has moved in different ways in different countries. So it's nonsense to set a global target for each and every country by which used after some months you say there's no equity, this is terrible, yeah, while the virus has been behaving in very different ways. So if you look at data, which is important in think tanks, yeah, what you see is that the countries and I would say high-income countries, most developed countries, has moved very much faster in terms of mortality and has higher rates of deaths, etc., etc. So the logic is that if you target the fight against COVID, you move faster in those countries, and you if you want to stop it in a global way. Of course, the virus affected most cities and countries with high and very intense mobility and international mobility. Of course, it's affected more big cities. Yeah. So the issue, the first very important issue is that what is the logic in which we should set up the equity goals that we put in the discussion? Because from our point of view, the first issue is health, is epidemiological. Is not we are not trying to solve equity problems because we have the COVID. The world has huge inequalities and inequities set up from many centuries ago. The pattern for that is started by Sustainable Development Goals, and we are moving that. We need the development everywhere in every field of our economies and societies. Yeah, but here it's a health problem that we should first point from this issue. And having said that, what I would say is that in the region it has behaved. Let's say, I would say in that pattern. Some countries that are relatively isolated has lower rates, like Nicaragua, Haiti, Venezuela, because they are suffering dictatorships of communist regimes. So those countries have lower death penalties because nobody's traveling there. Yeah, so they are relatively isolated, lower vaccination rates. Yeah. So the first issue there is, well, if you want to bring equity and increase, let's try to do something against and to protest against dictatorships and these communist regimes in the region, or unstable democracies. In other countries like ours, the pattern has been shifted in the epidemiological way. So we privileged, for example, starting in big cities, because big cities are the hubs for mobility. Those are the hubs for contagion. So big cities, of course, we target in elder populations. Yeah. So if I'm a child, well, that would be an unequitable distribution of vaccine of our region, but we target to most affected and most at-risk population. So there is something good about doing in not an equitable way. We need to be strategic, not same percentage for elder, for people with chronic diseases, etc. There's a health issue that should be in the first line, and that was the pattern. In Colombia, vaccines are paid by the government, so and it means it's paid by our taxes, everybody taxes, company taxes, a lot of donation from companies, and we also are there to COVID, so we received also vaccination, but I think that everybody is receiving without differences. There is no, let's say, storytelling inside the country regarding population not having access and being treated in a different way now, because well, we have a wonderful healthcare system with 98% of healthcare coverage for everybody. So I think that it has moved. We have had some difficulties, of course, because there are logistics to arrive to far cities, small towns, etc., in the jungle or in the Pacific region. Well, the fortune is that those regions are naturally isolated from the virus, so they are behind the curve of vaccination, but they have been protected and they have the lowest rate. So I think the issue has been strategically directed, and I think that's why we are moving. I would say we have been moving in a proper way.
Right. Thanks, Carlos. Well, I was going to come now to Neelesh, but let me just hijack the dispensation of the chair, of the moderator rather, to respond to a question that has been asked in the chat box by Aryan Dihan. And he says the question is directed to Kwame, but I will not. I'll deflect it instead to my colleagues from the Institute of Economic Affairs because they're giving the perspective. I'll give my perspectives last. So the question is this. Question for Kwame. You called the lack of access and supply a market failure, if I heard well. Yes, you heard well, Aryan. But public health is never market supplied. Isn't the big question why the global goods function is failing? Arian from Ottawa, thank you for this excellent panel. So I'll ask my colleagues, Jacky and Leo, speaking about it from the perspective in Kenya, and some part of the reason we actually asked Southern Voice to allow us to host this panel is because this is a question we grapple with. To what extent do you think that the question of access, especially global access, is a market failure question? And how do you define vaccination? Is it a public good, or what kind of good is it, and how does that play? So could you respond to Arian's question? I'll ask Leo to go first, and Jacky after that.
Yes, as we all know, the vaccination program, which is a disease control, is a public good. So generally, a global mass vaccination should be a global common. However, the vaccine itself is a private good. And that's why if you have a population of, like the way India has a population of 1.2 billion, you have to plan for that, more than 1.2 billion. You have to plan for more than 1 billion doses. So the vaccination program in itself is a global common, is a public good, which is a global common. However, that you need to emphasize that vaccine is a private good. That's why it has to, if it's the person in the capital city, the person in the most remote area, that vaccine, that there has to be a plan for each and every person's to get that vaccine. On the question of global, the supply access, you know, generally vaccine manufacturing and vaccine production is a complex market, is more of a complex market, and because predominantly it requires some level of human capital to be able to get that research, to be able to get it. It also requires resources, abundant resources, and that's why things, initiatives such as Operation Warp Speed that was done by the US president was able to get things moving. And when you see the value chains for whole, like the 7 vaccines that have already been authorized for emergency use, most of them are in Europe and Northern America, which is and part of Northern America, which is mostly predominantly European and the US farms. So and that goes to for everything, whether those will be those people who manufacture bioreactors, lipids, all those other things that are required in the vaccine production are farms that are based in outside there. So that's why, just to respond to that. Thank you.
All right. Well, I think let me add something else here before I come to Neelesh, so we can get the conversation going. One of the things that you asked is, and I understand, Arian, your question. Your question is, isn't public health never market supplied? Now, if you come to Kenya, which is where we live, that statement is actually not true. The government provides certain services and has constitutional responsibilities for public health obligations. But if you look at the total spending in health, close to 56, almost 60% of spending in health comes from private pockets, meaning that the major payer for for health consumption, if you may call it that, is actually the Kenyan household. So that's the first point. The second point, which you might find interesting, is that sometime in May of this year, a couple of Kenyan corporations arranged for the import of the Sputnik 5, which is basically the Russian vaccine, which was more available at that time relative to others. And some Kenyans brought it in. I think about 30,000 or so doses were available. Of course, the government of Kenya clamped down on it later because of concerns about quality. But basically, Kenyans were prepared, and there were corporations in Kenya that were actually prepared, including we at the IEA, to get people back at work. We're actually prepared to pay privately for our colleagues not to get them well. Reflection of the fact that the state of public services had an effect, or the government responsibilities and the extent to which government takes its constitutional responsibilities seriously had an effect in part of what we see. And so this vaccine equity argument sometimes also reflects domestic political economy questions, which is the next question we'll be answering. But let me go to Neelesh and ask him whether he has any responses to question 2, which is basically, how did the government of India respond? And were there any political economy considerations in India which made the response? Because I also was quite excited when I heard that India has 1.1 million vaccines administered. Of course, it's 40% for complete, and obviously for the others, it's coming along. But given where India was in February, this is a fantastic response. So Neelesh, please let us know what did government do that made that possible?
So thank you, Kwame, again. And see, if you look at the way the pandemic started and how the India started its response, the first thing Indian government did was to commit capital to the pharmaceutical industry and give them an assurance that the government will buy their doses. So that was the first and foremost thing which gives confidence to the industry leaders to invest more. See, everybody was aware that in the beginning itself that this is something huge which is going to come up. And the way everything was, the world was shutting down, and the way the West was experiencing mortality, and it was never seen before in kind of health systems which the US and Europe had. And we in India were literally terrified that what will happen when this kind of scenario happens in our country. So, and because we at India didn't had such sound health systems, so the contrast was really stark when we saw initial days that how literally US and Europe was struggling. That was the first thing the government did, was to commit a capital. Second thing was, even after the first wave, when things were settling down, India committed to provide COVAX and the global community. And in fact, we were able to supply close to 40 countries. And initial days, we supplied before second wave close to 20 million doses. And even if you look at the recent most data, we have supplied to 94 countries more or less, and it includes both via COVAX and direct shipment also through commercial arrangements. So India always wanted to be in a position to supply to the world. But sadly, we encountered the second wave, and second wave was something which you can say something like a question out of the examination out of course question came, and the whole system was grappling to respond to that. Good thing was that because we had prioritized our initial vaccination for the medical workers or the healthcare workers and the senior citizen population, so we were still able to mitigate the mortality rates despite having a huge challenge. Coming to the next, your economic forces. So see, it is a market failure definitely, because whenever we anticipate a kind of demand scenario, because still the demand is huge, and the whole scenario is like maybe we will be requiring booster doses going forward. So every industry leader knows this thing, that there is going to be a huge demand, and that was the precise reason why so many companies have come up with the vaccination, such as vaccine products in such a short span of time. It is never heard in the history of pharmaceutical industry. Vaccine development used to take more than 5 years in one go. You take the recent most example of Ebola. The vaccine development took more than 6 years, and in COVID-19 we got a vaccine developed in flat 1 year. So where have we heard this before? Never. So every industry leader knew that there's going to be a huge demand, both from the developed world and also from pockets where the affordability will be low. And the way the industries have been functioning since ages is that they recover their R&D costs from the West, and they supply the East and the so not so rich countries with at an affordable price to cover the humanity. And that's how the world moves on. But in this case scenario, we floundered in a way where we couldn't invest enough capital at the initial stage for the global good. And that's where I think we sort of failed as an institution, as a global community, and as something which we should have done more.
All right, thank you, Neelesh. So I'll come back now to the question about, I mean, we've tried to avoid the A word, the vaccine apartheid word until now, but I think we need to purge it, or at least discuss it openly, because it's one of the most emotive ways in which this inequity has been described. I'm not too sure what every one of our panelists thinks, but what I'd like us to wrap it around is basically, how did this question play out in the country in which you are, or at least with your knowledge? Is it an accurate description of the inequity that we've discussed so far? And then we can start to think about how do we think about global cooperation, because we accept that vaccine, or rather we accept that pandemic control is actually a global commons. How the WHO has done is a different matter altogether. I think it's got a decent job given the circumstances and the politics of it. But I'd like to hear from our panelists about what issues of political economy of vaccine production surfaced. I think some of them have been addressed by Neelesh and my colleagues here, but let's hear what they did. But what do you think is the best way for some global cooperation, and how could it have been better done, given that obviously the knowledge, some of that knowledge was invested in through public resources, primarily private public resources from the West or in northern countries, let me say high-income countries. I think that's a more accurate description. And then everybody else waited for that to develop. The short time period between the pandemic and when the vaccines became available, I think is a blessing to everybody. It could have been worse. But then what kind of political considerations? I'm talking here of the hoarding. Many people talk about, and I think Canada gets pointed at quite a bit, saying that, look, it has vaccines to cover its population 3.5 times. Some estimates that I have say 4, 5 times, even 7. Whether that's true or not represents political considerations, because why aren't countries able to share? And this sharing thing is a question that's difficult as well. So let me reverse the course. This time I'll start with Fenny as well. So Fenny, tell me what you think are some of the fixes, and what do you think about these talks, this very emotive word, vaccine apartheid? It's not a word I like, but I think we need to purge it, because it's one of the things we are hearing about why people are interested in this question. Is it real to call those equity questions that we've debated so far as apartheid, and how should we respond to the fact that there's inequitable access, which harms everybody by day, because for as long as this vaccine continues to, for as long as the virus continues to move around human populations, it's going to be much, much more difficult to clamp down. Fenny. Fenny, I think you're muted. We can't hear you.
Okay, sorry about that. So I've been on different platforms where we have talked about these issues to do with inequitable distribution of vaccines. And one of the things I've said in previous times, and I continue to hold on to, is that we are never ahead of the queue when it comes to negotiations about supply or, distribution of vaccines that are really needed. When the world started moving quickly to look at vaccines, we were still, grappling with issues to do with testing and treatment, and that was not at that time our focus or our priority. And so we had to catch up really fast. And the same goes for everything else that has to do with vaccines and issues to do with our health. For so many years, we have relied on external funds to support our health systems. We've talked about this. We've made several recommendations over the years. Year after year, we are saying, let's continue to invest in our health systems, in building our infrastructure to support our health system. Mind you, Africa has the greatest burden of disease, and yet we are not investing in the system, in our health system to support our needs. And so, yes, we are crying out against all that is happening globally, but we really need to also do our homework. How much have we invested as countries in research and development? For example, I know that years ago, the African Union had mandated that countries at least spend 1% of their GDP on research and development. And we haven't done that as countries across the African continent. So we are in a place where we have to go, unfortunately, begging for vaccines so that we can meet the needs of our people. So really, it is time to look within and start, critically looking at how we can start producing our own vaccines on the continent. A lot of information is out there as to how we can do this, create hubs. So we'll have a hub in West Africa, North Africa, South Africa, East Africa, Central Africa, so that we can, within our own networks, within our African networks, build what we need in Africa. We have said this for several months, and we really need to start moving. I know that the South African government has made a lot of effort to get this off the ground. So there are, collaborations between private pharmaceuticals to manufacture some of these vaccines in South Africa, for example. We really need to go back and sit together as countries and see how we can develop going forward. Relying on Western countries or external donors is not the way forward, because there'll be future pandemics from what we are seeing now. This is not the end of the story. So we really need to start investing critically in our research and development so that we can build structures like India has built. So when it came to a critical point, India decided we will not give the world. And many of our countries started struggling and looking elsewhere. When India said we cannot give the world any more vaccines, all of us started looking elsewhere. We should build our capacity to a point where we can also produce our own vaccines and not rely on everybody else to do the same. This is a wake-up call for us. Yes, there's vaccine apartheid, but we can also look within and build our systems so that we can provide for the needs of our continent. Thanks.
Right, thanks. So we are at the tail end where we'll be talking about what governments have done differently, so that we can come now to the main question and answer. So I'll come to Jacky and let the ladies speak first, and then I'll finish up with the gentleman. Jacky, what do you think countries could have done better, especially on the continent? Of course, Fenny has decided that one part of it would be to actually have local domestic production.
All right, thank you. So I think I'll just actually build on start from where Fenny has left. And I think the main challenge that we see, and especially in the lower income and lower middle income countries, has been limited investments in the public health systems. And that has reflected in our ability to purchase and our ability to distribute and deploy the vaccines. So I think as a starting point, we need to have governments increasing their level of investments in our health and healthcare system. You know, for instance, in Kenya, when the pandemic, with the outbreak of the pandemic, it came at a time when already our entire health system was I could say suboptimal. If you look at the level of financing, is really low compared to, for instance, other countries in more developed nations. So we've looked at the per capita allocation to health, and it's about $25 in Kenya, and that's compared to countries like in Europe where it's the same, is around $4,000. So you can see already that limited investment would not be likely to yield optimal results, especially in an instance where you expect a system to be resilient, to be able to take care of any surges in or outbreaks in a pandemic like what we had. So I think the main emphasis here, what I'm stating is we need collectively to look at how much we are allocating to healthcare systems, so that we do not blame the condition or the claim for vaccine apartheid, while as individual countries we are doing what we are doing is not likely to yield optimum results. So also to add to that is just to say that if you look at the countries that have had better success rates in terms of vaccinations and vaccine uptakes and distribution, these are countries that have been able to, that have great reserves, that have, if you look at the amount of allocations that they do to their health, cannot really compare to what we have. So I think that's one of the things that we need to do. Then the other issue is coordination. We can have proper coordination between countries that are involved in the production and distribution of the vaccines, together with the other countries that rely more heavily on donations and other support from the global north. So as a starting point, that's my take.
Okay, well, let me go now to Neelesh. I'll come to you for last. Look, Neelesh, I'm hearing from the two ladies that one of them is domestic production, which is self-reliance domestically. I'm not too sure what you think the economics of the production of vaccines is, partly because even in India, I think SRI, one of the largest producers of vaccines globally, is not a public firm, but is actually a private firm that has invested, given the capacities that exist and all that. So that's the first point. And the second is, do you think that we can actually just throw money at this at the vaccine problem and solve it? Let's hear from you.
Thank you. Frankly speaking, I don't think it works that way. What I think is we live in a globally connected world, and we should look at collaborations and cooperation. One of the things which we were missing throughout this, and we could have worked more, in fact, through even UN organizations or otherwise also, was technology of transfer agreements between different companies, so that the actual production could have been taken up. And I think that is something which has been missing since long. And even within India, we have experienced where there was an initial reluctance by the two major producers, one Covaxin and the other Covishield, to share it further. So even if you look at the history of Covishield via the Serum Institute, they got technology from AstraZeneca through the Oxford University. So these kind of tie-ups, which if they are sort of nurtured and if they are sort of brokered through UN organization, I think that would help much more, number one. Number two, vaccine capacities, they are difficult to sort of scale up in a short span of time, because the vaccine manufacturing itself is a cumbersome and a complex process. So it is not something which can be done overnight. It requires a sustained policy direction, and it's a long-term project. Even any country who wants to develop that base. So there are two things. Developing a pharmaceutical manufacturing is different from developing a vaccine manufacturing base. So these two things are entirely different, and it's easier to develop your pharmaceutical manufacturing as compared to your vaccine manufacturing. So if a country wants to invest into developing a vaccine manufacturing base, it's a complex thing, and it takes a long-term policy direction that a country has to take. And definitely, if a country takes that, nothing like that. But to support that, the other global organizations should look at technology transfer agreements to begin with, so that things can at least be fast-tracked. Number two. Number three, the other thing which I felt which was missing was, or which can at least bridge this gap, was the lack of efficient data from the low and middle income countries. So if we have good health data, and if we are able to prioritize whom we need the vaccine foremost, and then we can sort of negotiate that we need at least these much doses for these vulnerable populations or the high-risk populations, then I think it makes even sense for anybody who is in the chair or the decision-making chair to sort of allocate those resources. So what we have been seeing, what we have been doing is we have been asking for ad hoc grants kind of thing, like we need these doses, but we do not have actual basis of how we are calculating that, or what exactly we are going to do that. And that leads to a situation where every country, because of their own geopolitical sort of compulsions, they have to first cater to their own needs. And when it comes to global good, they sort of backtrack from that, because there is no solid evidence, or there is no solid data-driven decision making which can help them reach that goal. So I think these are the three things which, if we could have done better, we would have been in a much better state. Thank you.
All right, Carlos, Felipe.
Okay. So let me start by the first. I think you suggested to address the issue of the apartheid concept. In my point of view, I think that it's a misfortune and to use this statement, and it's not fortune to be used by the head of the World Health Organization. I think that the apartheid is we know it is an explicit mechanism in which people oppress other people and set up a system in which you let's say get this segregation. Here it has not passed. It's not an issue. Developed countries has not done that. Industry and pharmaceutical companies has not done that. So I think that it is a terrible use of the concept to describe the situation we are living, and I think that we very soon need to forget this concept, because I think that it separates, it breaks the conversation. I think that the issue, and I agree in most of the things, and Neelesh has mentioned, this is an issue of understanding the not only the long term, but the long term of how to make our people secure in terms of healthcare provision. So in the country, we had in the early stage of COVID, one big proposal of a huge national national facility to develop vaccines and to produce vaccines, take out IP system and patents, etc., and we are going to make it because we need to provide security for and access for our people. After and the process is starting to be discussed in the Congress of Colombia, and we have a lot of conversation. And after doing the analysis and the data, etc., the conclusion, I think, was clear. First, was not possible for this pandemic. If you start building facilities at this stage, it is going to be for the next pandemic, but not for this one. Yeah. So focus in getting a strategic and taking a strategic decision of acquiring the vaccines, distribution, etc. Second, we address the issue that we need to, of course, to strengthen the capacities, as Fenny was mentioning. Of course, improving the research, knowledge transfer, and the capacity to develop and to produce vaccines and other pharmaceutical goods, it's absolutely necessary. So the government has advanced a lot, and there has been a lot of diplomacy with the agreements with South Korea, with China, with India, in order to understand how they have strengthened their research and production capacities. So we are setting agreements first with those countries that have strengthened their local capacities, but also with companies, because pharma companies have done a lot of agreements for knowledge transfer. But how can you pretend to have knowledge transfer agreements in your country if you are saying we are going to take out this issue of intellectual property? No. We have had this huge success in having vaccines so fast because we had, as humanity, established a global intellectual property system that has worked. In my field, which because I am a medical doctor, 60% of the tools we use for healthcare come from the basis of an intellectual property systems. And I'm not talking only about vaccine. I'm talking about all medicaments or diagnostic tools, prevention tools, etc. 60%. So if we, let's say, attack the intellectual property systems, we are attacking the future of innovation of whole healthcare. So take care, was our contribution, take care. Let's understand that IP system has been absolutely crucial in having the solutions and in continue having the solution for the future. So let's try to get very connected, strengthen the capacities by building public-private partnership, not only in the local, but also in the regional and international level. And then we are going to be much better prepared for the next pandemic. So it's an issue of setting things like this. I'm happy to say that I see that the country is moving in that direction, and I would really advise sometimes some things, because all these issues of moral superiorness seems to be easy to say. Well, take out industry from the business, take out patents from the business, take care of that, because it's because we have protecting those who invest to create, to discover, that we have the solutions in place available, and focus more on what, for example, organizations like the World Health Organization should have been doing. We should have had a much better a global cooperation system set in place before the pandemic. COVAX was really developed during the pandemic, and even everybody was saying that a pandemic is coming. So what we should focus is we need to strengthen and to really rethink about World Health Organization and its role and these global cooperation entities, because they were not doing their job right. They're setting wrong targets. For example, this equitable issue is a wrong target, and they are distracting the discussion, and they have not set systems properly, like COVAX, like we're doing for the next pandemic. Of course, we need to strengthen and to improve mechanisms like COVAX that improve the reaction, the global reaction for everybody in the future. But that's a lot of things that we need to do in these global cooperation entities.
Right, thanks. I know Fenny's hand is up, but let me have, because we need to go down to the Q&A because many people are waiting. So Leo and Fenny, please, 1 minute each, and then we can go to the Q&As because we have quite a number of questions lined up. Leo.
Yes, so for me, I think that the biggest imperative is to, at the global level, is to raise production so that countries can put in more money to be able to buy those vaccines. We know that the uptake now, if you see from data and what people speak, most like for the case of Kenya, most Kenyans are willing to take up the vaccine, and the global availability at the global level is a good thing. So just to say on the production side, it's very difficult, even if you have a manufacturing plant. And even without the raw materials, it's a combination of so many factors. And I agree with Carlos that this has to be something that, for the long term, thinking along the long term purposes, for long term purposes, because zoonotic diseases are becoming more prevalent. And this is the SARS-CoV-2 is the second version that we're seeing in 2 decades. So, and we've seen other flus, influenza, and the rest of the things that these zoonotic diseases are going to be with us for the next decade. So it's for a long time. So it's imperative for African governments generally and globally to think about this as a long-term issue. But at present now, it's not one of the things that can go very well, because even the plant in South Africa is finish and fill. So it's not in the earlier stages of vaccine manufacturing.
All right, Fenny, before we go to Q&A.
Yeah, so this will be very quick. I agree with Carlos, Leo, and Neelesh that yes, the issues about production, producing our own vaccines should be a long-term issue. But then we have to start making it a priority now. We have the tendency to push things back. And so we keep on pushing these things back, further back, until we are in crisis. And we know what Ebola has done to all the countries that were heavily affected. They are still grappling with issues to do with unemployment, poverty, and several other issues, mental health issues. And so the economic impact of the COVID is not going to be seen just in the short term. It's going to continue to play out in the long term. And yes, we have long-term goals, but we should make an effort to shorten them, because the impact of COVID will not just be something that we'll feel today. It will carry on in different ways, in different pathways in the future. So yes, it's a long-term goal, but let's make it a priority today. Thanks.
All right, I'll go down to the Q&A, and there's been a request from Moi Leshimora. I hope I pronounce your name correctly. He'd like to respond to some questions, and in the interest of equity for questions as well, I'll confine you to 2.5 minutes so that we go back. So please ask your questions, Mr. Moi.
Thank you very much, Mr. Moderator, Kwame Owino. I don't have a question. We were invited by, just a minute, sorry about this. Thank you. We were invited by your good selves to participate in this session. And the Ministry of Foreign Affairs given its mandate as being the interlocutor between our government, our country, and the rest of the world. Coronavirus is a global pandemic. And this has informed even our action as a foreign policy entity. So I didn't have a question. What I had is a submission to this conversation as you seek answers to the key issues. I see your invitation to be focusing on three things. You allow me. The political economy of production and distribution of COVID-19 vaccines in selected countries. I see that as a distinctive issue. Interrogation of the political concept of vaccine appetite, very distinct from the first one, that is informed by the realities of the first issue. And finally, the proposal for multilateral cooperation in production and distribution of vaccines. I would like to skip the first one and I want to thank Kemboi and Jacky, Kagume for putting Kenya's perspective in line. And I have seen that there is a question about the distribution of vaccine accessibility across Kenya. I will advise that the inquiry looks at the website of the Ministry of Health. There is a day-to-day update. In fact, today's update is already on the website, and it gives you a breakdown among our 47 counties. It is important to note that it's not just a matter of access, but a willingness to participate in the vaccination program. So I'll skip a little about the first aspect. From a political economy, I think it is important to learn from our lessons as a country. The National COVID-19 Deployment Plan of 2021 is very instructive on the government way forward on this matter. And I think as an institution of policy formulation, and given your capacity in analysis and research, we'll invite you to look into this. I know colleagues in the Ministry of Health are very available and willing to dialogue with you on this national COVID-19 deployment plan. It may have its own challenges, particularly informed by the assumption of access to vaccines, but I believe the 10 million target by December 2021 and 50 million by June 2022 are very reliable, as ambitious they are. If you look at Kenya's vaccination story, we are doing almost an average of 1.2 million between when we started in March and now when we have acquired 9.7, of which, of course, some are partially vaccinated. The 15 to 17 million target by June next year is quite something, but it is realizable. It's also important to acknowledge the partnership that we've received from some 20 countries in access to this vaccine. However, this access has not come without its own challenges. The restriction and of course the open inequities and unfairness in access and distribution of the vaccine cannot be deleted by the fact that right now we're having more and more partners forthcoming in availing the vaccines for our countries. I would like to go a little about the issue of the political economy of production and distribution of COVID-19 vaccine in selected countries. With the pandemic still going on, there has been a massive push for vaccine development through large subsidies to research and development to drug companies, pre-orders of vaccine and other support by some major world powers. This ultimately lead to the successful development of several effective COVID-19 vaccines in an unprecedented short time frame. What this means is we started well. We started in a good way. We started in several countries participated in the beginning. Of course, Kenya and South Africa are part of this process where it started. But at that moment, the research on vaccine for COVID-19 was seen as a common threat to humanity, a common threat to human life. But when the vaccine became successfully and were released, it became commercially interest-based. So we've seen a transition from what we call a common goal for humanity, to save human life, to what I can say commercialization, as in many cases before, of the vaccine itself. This is the root cause of our understanding of discrimination, the vaccine appetite, which I'll speak to very briefly.
Mr. Moi, I apologize, but we need to be closing in 15 minutes and we need to give other people a chance.
Thank
so
you.
If you have
I'll skip
if you have a statement,
to focus on
we'll circulate it, but please finish in the next 1 minute, please.
I shall finish. I summarize my view on this issue of vaccine appetite to lay the facts bare. One, that coronavirus doesn't present existential threat to humanity. And therefore, its response across the world must be equitable and fair to all nations. We see the vaccine, therefore, as a global survival commodity, and that nations should have equal share to access to vaccine. I was in the UK when they had the British Awards, and they recognized the AstraZeneca team. And all that was referred to Kenya and South Africa is that they were volunteers in the testing. That informs the need for us to have a deeper discussion on this. On the issue of the way forward, what were the major lessons? And I think this is what should inform your policy review. One, a feeling of we are alone among the developing countries. Two, an haphazard global reaction to the pandemic. The World Health Organization did try a lot, but the variation in the response from our own countries differed in the sense that it created an unorganized reaction. A major awakening on the need for timeliness in the response, which translates to preparedness. And this is what the last item I would like to speak to. How do we build a new multilateral cooperation? One, we need a global science solidarity and unity to boost research and response to health calamities. I think this is something that you could easily put on the table of the World Health Organization and they will be agreeable. Number two, look at alternative mechanisms that prompt multilateral action. We are looking at this from the Commonwealth perspective. India is a major player in the Commonwealth and a major producer of the vaccine. Is there a framework in which the Commonwealth can itself prepare to be part of this multilateral action group on response to national health calamities? Number three is innovative partnership. We have seen the problem of how to deal with patents and intellectual properties, and the element of special status agreement between states, and even approach multilateral cooperation framework can assist. The deeper involvement in the private sector leadership is paramount. Those countries who are producing vaccines now have put a lot of emphasis on their private sector leadership. The second final line is the investment in technologies for healthier communities. I realize even from my experience in Kenya, the need for increasing our expenditure in public health is good. It's an agenda, it's good. As I, of course, learned from the Kenya Universal Health Agenda and the Big Four. But we need to invest on technologies for healthier communities so that we can be able to produce through value addition ways and means to deal with health challenges. The final one is building connectivity that promotes flexible trade regimes for survival commodities. Again, I say that vaccine is a survival commodity, and we must look for ways to develop flexibility in our trading mechanism. I want to thank you and end up with a fair call from our point of view, from a multilateral cooperation point of view. The inevitability that the world global institutions that deal with common challenges like health must go through reform to ensure equitable and fair representation of regions and countries. This is a topic we'll have loved to get in depth, but we thank you again, and we wish the discussions a successful end.
Thank you very much, Mr. Moi, and our apologies. The next panel starts in 10 minutes, so thanks for your comments. If you have any written comments, we'll find it and we'll make it part of the report and the record for this. We have other questions which I'll go through very quickly. So there's David Indeje who asks the panelists, what alternative models can be used creatively in the use of financial tools to ease access to vaccines? We know the challenges on patents, the formula, and among others, but what options do we have? I'll read the questions and then I'll distribute them because we only have 10 more minutes. There's also a question from Kenya to Carlos, which is, Carlos, can you clarify whether intellectual property law impedes or facilitates global development on vaccine development? I mean, global development of vaccines. I think that's the question. And then one question comes, well, that's been asked already. So let's respond to those, and I'll divide them in this way. With respect to the question on whether intellectual property law impedes or facilitates global cooperation on vaccines, I'll ask Carlos and Neelesh to answer those. And then I'll speak to the last question about what we think what we think, the Kenyan question specifically in terms of coverage, I think Jacky and Leo have covered that. And after Carlos and Neelesh have gone through, I'll have to wind down by asking each of us to make our final comments. So let's start with Carlos, your comments about intellectual property and law, and vaccine development.
Clearly, intellectual property facilitates global cooperation on vaccine development. Intellectual property, a setup intellectual property system strong and clear for everybody, allow the possibility for the vaccines to be developed in the different centers in which they were developed, and allowed the agreements between, for example, universities and labs to, let's say, define the roles that they are going to, that they would be having on the production and distribution. So clearly, we need to be thankful on having a strong intellectual property system globally, because that was one of the big bases on having this very fast, incredible response, and this huge number, more than 160 vaccines currently in development and willing to enter in the next phase. So definitely that is the way, and that has been the way for most healthcare tools that we use, as I mentioned previously. That's why we really need to be very prudent and serious when let's say doing statements regarding intellectual property, because it's the basis to strengthen what we can do in lower income and developing countries in order to have better capacities to respond to the next pandemic.
Neelesh?
Yes, I agree with my fellow panelists, and I think that the intellectual property, if you look at how the vaccine development has got a super fast speed, and that intellectual property law and all those things have helped that. We now have a mRNA vaccine, which was nowhere in the world before. We have adeno-vector-based vaccine, which we were not able to produce before. So we have newer technologies coming into even the vaccine development. And if you look at the traditional method, the subunit or the killed vaccines, they're also available. So the whole gamut now, or the whole spectrum of the different technologies are getting covered because of this, the free spirit or the innovation that is being allowed. But what is more is important is that while we support this IP regime, we also need to have global cooperation mechanisms, and they cannot be sort of last moment cooperation. It has to be a long-term cooperation mechanisms where once we support these IP regimes, we also have an understanding with the global industry leaders that in times of crisis, at least this technology will be shared with the low and middle income countries so that the production capacities can be uniformly distributed. So I think those arrangements need to be long-term and should be in place beforehand, and then we support the IP regime. So both goes hand in hand. Thank you.
Right, we come to the point now where we're going to ask our panelists to make their calls to action, but also more importantly, to make their final comments. So without prejudice, I'll ask the ladies to go first. So Fenny, if you have any other questions, but also your closing comments, you could go now.
Thank you very much. In closing, one of the things I need us to also reflect on is that the cost of distributing vaccines are borne by governments. And these are not part of the discussion when it comes to vaccine acquisition. To actually transport vaccines across different areas, urban areas, rural areas, costs a lot of money. And so we need to consider how to close that financing gap when it comes to distribution of vaccines within our own countries. Let's look at cost-effective measures to be able to do the distribution in an efficient way. Finally, I want to also draw our attention to the fact that we need vaccine diplomacy. We need to find ways of negotiating with our suppliers globally to find ways of equitably distributing vaccines and accessing vaccines for the numerous people who need vaccines in Africa. Thank you.
All right, Jacky.
All right. So in closing, I think, first of all, thank you to Ambassador Lemoshira for his provided us with some useful insights in terms of some proposals for the way forward and what we should do to prepare. But just to add, I think transparency would be a key thing that nations need to emphasize. Transparency, especially in the entire supply chain of vaccine production, vaccine distribution. I think it will help ease some of the anxiety and some of the claims that we've had relating to the vaccine appetite. So emphasizing that, especially for producers, in terms of who receives what and on what schedule would help. Then secondly and separately, I think there's need for countries to explore how they could eliminate export restrictions, especially in terms of the supplies that are required in production of vaccines. So there's need to just urgently look at the areas that have high tariffs and certain bottlenecks on COVID-19 vaccines, and then look at how that can be eased to facilitate production and again distribution of the vaccines. Then I think the last thing is some sort of regulatory streamlining and harmonization, and this also responds to the question that was asked on the patent laws and the laws that are restricting or limiting the production of vaccines. So various regulatory authorities around the world could look at how to create some sort of consistency and standardization in order to facilitate or fast track or expedite the approval of vaccines. Then lastly, again, just to re-emphasize the issue of financing, so adequate or increasing the level of investments, because as has been said by some of the panelists before me, this is not the last of pandemics. We are likely to see another, maybe another variation or another variant of this. But so what the lessons that we've learned now is that the inadequate infrastructure around health only serves to make the situation worse. So we need to learn from this right now and find ways to increase the investments. Thank you.
Right, yeah.
Yeah, so for me, it's 3 issues. The first one is globally to use the existing supply chains for those manufacturing firms that were not able to, vaccine manufacturing firms that were not able to get their vaccines beyond phase 3, they were not able to get approval. So that, because that is already existing capacity to be able to ramp up the global production of vaccines. The second issue is deployment. I think we need to emphasize that several countries in Africa were not able to deploy vaccines because of the lack of that capacity, because there are other things that are required outside just acquisition of those vaccines. So countries like DRC, South Sudan. Another thing, the third issue is now part of the way countries can finance cheaply these vaccines is to issue small-time COVID bonds, less than 2% of GDP, and be able to get ahead in the queue. Because part of this mobilization of resources, because there has to be a low middle income solution to this, other than reliance which means if you're able to get a COVID bond, which is like a 5-10 year, taking that expenditure into the future, because the effect of that to the economy, of COVID to economy, is still much small, is bigger than what you're going to spend on the vaccine production. Thank you so much.
All right, ladies and gentlemen, I think our time has run out, unfortunately, so that means Neelesh and Carlos lose some time. But nevertheless, we can continue with this conversation offline. But I think I'd like to state 2 things. The first one is it is inevitable that countries have to be prepared both internally and globally to be able to make the best use of available medical technologies. So we see that the constraints are not necessarily based on some prejudice that has been decided. For that reason, I think the general the general tone of discussion in our forum today says that to call the differences or the inequities vaccine apartheid is a form of reductionism that actually makes, almost nearly makes this discourse completely a nuisance. Partly because there are market failures and fractures that are also very, very real. There are public sector weaknesses individually in the countries that we've spoken about here, but everybody is trying their best to do well. And also their political considerations. So if a country is very concerned about a pandemic that comes in cycles, it may be less willing to actually distribute or share vaccines with others. So what does it tell us? Our call to action must be strengthen global multilateral institutions. I think the epidemiological approach must also be based on the reality of the illness that we are dealing with. So that's the first thing. The second thing is that we need to diversify sources of vaccine production, but that in itself is dependent on existing domestic capability. So if a country does not, for instance, even manufacture a certain complex product, I think to try and impose vaccine production at this moment might be throwing good money after bad. So we need to actually ask what's the level of preparedness at state level and at the same time to come about. Regardless of what we think, and we've heard from Moile Moshira from Kenya, representing Ministry of Foreign Affairs in Kenya, we're grateful for his being here. There's a feeling of abandonment. So there's some discourse that we need to drive as think tanks, generating global understanding about what the political difficulties in all parts of the world are, but nevertheless, knowing that if we use epithets and we use very, very divisive language, I think our problem of making sure that vaccine equity is achieved will actually be longer. So I'd like to thank all our panelists today, starting with Felipe, Neelesh, Fenny, and my two colleagues, fantastic colleagues, Jacky and Leo, and for all of you for being a very nice audience. Thank you very much. I'm thankful to Southern Voice who have facilitated this discussion. We are grateful that we had this discussion, and let's hope that we can attend the rest of the Southern Voice conferences, which is still going, and a panel discussion that is following a few minutes after this. Thank you very much and have a good day. Bye from Nairobi.
Thank you all.
Thank you.
Thank you
Keep
very
safe.
much. And bye
Thank
from
you all.
Accra, Ghana. Bye.
Bye. Bye
Thank
from
you.
Nairobi.
Bye from Colombia.
Bye. Keep safe.
Bye-bye.
Thank you very much.